Well, first of all, I think the fact that we're all here indicates that we all agree that falls in seniors, injury is an important public health problem, and falls in seniors is particularly so. The impact in terms of morbidity, mortality, economics, and emotional suffering, I think, is indisputable. And I think we also, everybody in this room would agree that falls are a very complex problem. And I've heard it said that for every complex problem there is a simple solution, which is usually wrong. And this is, again, no exception. And that's, I think, again, why we're all here, because we need to be in the same room, because there are no simple solutions for complex problems. And I think working together and integrating is definitely a good idea. The reason I'm here is I was asked to talk about public health and introduce you to public health and what is the role of public health. I think that this is poorly understood by most people, what public health actually is, and this is something that I'm very passionate about. So I have no particular expertise with respect to falls prevention in public health. I was the MOH that invited Kelly and Mike Barrett and the Tudens and so forth to our MOH meeting, so I think by default I was asked to do this. So for those of you who are in public health, you can probably have a little snooze now, and for the rest of you, I don't know how, for some that might be a first date, and we'll see how it goes. So public health has been defined as the science and art of preventing disease, prolonging life, and promoting health through the organized efforts of society. It's a lot different than medicine and biomedicine, and we speak a different language and we think a different way. And I think if we're going to work together, it's important that we understand one another. And I've done both. So in public health, the community is the patient. So I think of Perth County as my patient, and I'm looking at how is my community doing, what are the risk factors for my community. And it's much more prevention focused than individual treatment. And in public health, we like to talk about the fable of the community by the river. So there's this lovely community by the river, and one day someone comes hurtling down the river, and very nice people, so they go and they scoop this person out and they save their life. This is great. And not long after, someone else comes down the river, and so they jump into action again. And pretty soon, this community gets very slick at scooping people out of the river. They know what to do in cold water, weather. They know what to do in warm weather. They've got very advanced technology and systems to go out on ice or in the water, and they're very, very good. They have a very good success rate of rescuing people from the river and keeping them alive and without head injury and other injuries. However, finally, somebody of course is from public health, says, why are all these people coming down the river? And you go and you look upriver and there's just a fence to mend, right? So public health, we're always looking upstream. You'll hear us talk about upstream. We want to look upstream, and we would rather be mending the fences and sort of letting more of the clinical people do the scooping and patching up. And 75%, so when you do that, when you look upstream, what you find is that 75% of what determines health is outside of the healthcare delivery system. And therefore, a multi-sectoral approach is truly needed. And just a reminder then of what are the determinants of health. There's different lists, but these are the ones by Public Health Agency of Canada. They're more or less all the same. And health services is only one of the 12 factors listed. And so most of clinicians will spend most of their time in health services, determinant of health. Public health spends a little more time in other areas of these determinants of health. And some really aren't, like income and social status. Who's really working on that? Somebody needs to, I would argue. For instance, going back to Mabel, I think Bernie introduced Mabel, who, she was identified, I can't remember now the story she actually fell, or was just identified at high risk, but she was given some information, and then she bought some equipment, and she went home with it, and her chance of falling has really decreased. But what I would say with you is that if Mabel doesn't have the money to buy the equipment, and she doesn't have the social support to help her reorganize her house like she was advised to, you can give her all the information you want, won't do Mabel any good. And so just to give you a flavor, what are the top 10 public health achievements? And you can see that they really are at the population level, right? So nobody asked us to create seatbelt laws, or pour fluoride in the water. So it's really not a one-to-one kind of work that we generally do. Having said that, you'll all be able to think of some. For instance, sexual health clinics, follow-up over reportable diseases. We tend to get interested when it could have a public health consequence. So if we don't treat the infectious disease and it passes on to someone else, that's where you tend to see a stronger one-on-one clinical role for public health. Although that's not the only example, public health also will often, historically, I think, identify gaps, which I believe is probably why we got into the dental game a little bit, because there wasn't universal coverage for dental services like there was for medicine. And it's not a small point. That's why I'm belaboring it so much. Because when you compare public health to biomedicine, it's really very different, because in biomedicine, the patient seeks care. They go to their doctor and they say, I have pain. They're motivated. And with public health, they're not asking us, as I said, to make them get vaccinated. They're not asking us to enforce tobacco laws and decrease the amount of alcohol outlets and so forth. So our fiduciary responsibility and our orientation is to the community, and our ethics are therefore different. So we recognize that when we immunize everybody, and we expect that to enter school, that there will be some kids that get side effects. Some are going to get a sore arm and a fever and so forth. We feel that that's the best thing for the community, however, to develop herd immunity. On the other hand, we try and use the least restrictive measures, so you don't just quarantine everybody all the time. There's reciprocity, so we explain why we're doing this, why this is a good idea, and there's transparency. These are very different than the biomedical ethics, where when I was sitting with my patient one-on-one, I'm just thinking about what's best for you at this moment and not what's best for the system or the community. So there are 36 health units in Ontario. They're all referred to as boards of health, which is confusing because they all each have a board of health as well. And so oftentimes people get very confused between the board of health, which is providing the governance, and the board of health, which is sort of considered the geographic area. And as everybody knows, there's 14 units in Ontario. My particular health unit is in the southwest. And we're not going to go through this whole thing, but public health is, this is where we get our mandate, our legislative mandate, mostly from the Health Protection and Promotion Act. There's other legislation that's very key for public health, such as Smoke-Free Ontario, Immunization of School Pupils Act. But this is our main legislation, and it actually provides for the creation and administration of these 36 boards, which are independent boards that can be sued, and they can sue, they can be contracted, they have corporate seals and so forth. All of this by way of explanation that boards of health, the people that sit on them have a lot of vested interest in what we're doing, right? They have a lot of responsibility. So they don't really have legislative powers, boards of health, except with respect to internal matters. And the Board of Health must appoint a full-time MOH, like me, but they can't direct the MOH with respect to sections 13 and 22. And I just mentioned that because everyone's always very interested in those orders that MOHs can write, and those are health hazard orders and communicable disease orders. But mostly we spend our time in providing public health programs and services. This is set out in legislation. The Minister of Health sets out that he can describe these programs and services, and that the boards of health have to enact them. And so our relationship to the government has been a little bit confusing. Prior to 2005, there was the Public Health Division within the Ministry of Health and Long-Term Care, but we also had the Ministry of Children and Youth Services with respect to our Healthy Babies, Healthy Children program. Then the Ministry of Health Promotion was established and things got divvied up a little bit. Then the Ministry of Health Promotion went away. It's kind of hiding. It's kind of a ministry within a ministry now. Is how they're describing it, but we do have a relationship with both the Ministry of Health and Long-Term Care. The Public Health Division is our main source of direction, where the Chief Medical Officer of Health, Dr. Arlene King, sits. But we also have the Health Promotion Division, and we also still have a relationship with the Ministry of Children and Youth Services. It gets a little bit confusing. Most of the so-called mandatory programs are funded 75%, 25% municipal, but that's not completely true. But according to the HPPA, the Minister of Health and Long-Term Care may make grants for the purposes of the HPPA. So although the government funds the majority of our programs, they just do so out of benevolence, and it is still up to the municipalities to get the job done. So strictly speaking, the government could refuse to give a grant at any time, the provincial government, and the municipalities would still have the legislative mandate And so this is sort of how our public health funding shakes down. And the main point of this slide is to show you that while the lion's share is provincial, and we spend a lot of time trying to find money. So we have little federal pots and little pots here and little pots there. But the lion's share is provincial. But $151 million that the municipalities put in is not insignificant. And again, they have a very strong vested interest in what we do through our boards of health. And this to make the point, though, I think public health is seen, it sounds kind of very all-powerful public health, and I can do a Section 13. When you look at if money talks, I think this slide speaks for itself. So the Ontario Public Health Standards, these are now what describe our programs that we have to, our programs and services that we're obligated to provide. They were launched in 2008, and they're grouped into 5 program areas. These are them. So the foundational standard is really the cornerstone of public health, the epidemiology, the study of the distribution and determinants of health-related states or events in specified populations, and the application of this study to control problems. It sounds so boring when put that way, but it's actually very interesting, and I think you all enjoyed the presentation by from the public health units about some of the data earlier, and it really is very important to understand what the real problems are in order to design the solutions. And then there's the chronic diseases and injuries standard, where the prevention of injury, and this is what we're talking about today. And just for your interest's sake, these are some of the other areas where we spend our time. And the last one is emergency preparedness. So this is the kind of work that we do in public health. As I said, it tends not to be one-on-one. We inspect restaurants, personal service settings. We might respond to complaints about air quality. Do educational campaigns such as STI prevention. We will advocate for laws like seatbelts, smoke-free Ontario. Right now there's a lot of work being done around nutrition policy, and should Canada be restricting sodium in food and doing a better job of labeling. We do school suspensions, travel clinics. I mean, it's very broad. And the places we work are kind of all over the place, and this, of course, can be used to the advantage of this collaborative. And the people we work with are very varied. And recently we have had to do a new kind of accountability agreement with the ministry, the provincial ministry, and I think Lynn's are familiar with these accountability agreements. And so these are some of the things we're being held accountable now for our funding. So the percentage of school-age children who've completed immunizations for hepatitis B, that's pretty straightforward in our minds. For us, the percentage of youth who've never smoked a whole cigarette, how we're supposed to move that indicator, gives me a little more cause for thought, and a little bit of lost sleep. And fall-related emergency visits in older adults, age 65 and up, is now on our accountability agreement. And so we had, I thought people enjoyed, as I said, the presentation of the data, right? So you start with the crude rates, and ooh, it can look really high, crude numbers, and then you switch them to age standardized, and they start to look a little bit different. But even so, even when you get a number like that you can compare, I mean, why would there be a big difference in fall-related emergency room visits in adults? Well, like as my epidemiologist will point out to me, whenever we look at emergency room visits for anything in Perth County, we don't have any urgent care clinics. All we have are emergency rooms. Yeah. So are we comparing apples with oranges, right? How far do people live from hospitals? Can they get around? What's the weather like? Do the rates change? So there's so many other fingers that will move that indicator. Even and having worked in hospitals and done the coding, how are people putting this information in? Because you can flip the indicator looking at it another way. I can remember when I was working in the hospital, we were like, well, why aren't our length of stays higher than everybody else's? And, why does it look like that? And, well, as a physician group, we were doing just a terrible job of capturing diagnoses and what we were actually doing. We weren't coding it. We weren't getting the information. We weren't putting the information on the chart. I hang my head in shame. And then the people who take that information, code it, couldn't capture it and pick it up and put it in, right? So family doctors and emergency room physicians and so forth, when I worked in the emergency room, you know, when there was 10 people waiting, the last thing I cared about was, you know, so if someone fell, was that charted as stroke, which led to the fall, which broke the hip, or did I write a hip fracture? I mean, I don't know, right? You don't get trained in that. So there's a lot of things that affect that indicator, but we are now in the same boat as you. As, you know, we've been assigned the responsibility to fix it. And if you take it to the logical conclusion, really, for public health, I mean, fall prevention really starts when you're a child. Then really right in a healthy lifestyle and a good education, so you can have a good job, so you can afford all the good stuff, and you don't smoke, so you don't have osteoporosis, so you don't break your hip. It kind of goes on and on and on. But getting to the meat of the matter, public health and falls prevention. What could our role be here? And this is taken right out of the toolkit. But certainly in terms of primary prevention measures, epidemiologic analysis, that's right up our alley. We can help with that. Having said that, you know, I showed you before that there were 36 health units, and they're not all the same. And the governance structures are different. And boards of health, some are autonomous, some are very embedded, and you have to get approval through the boards of health. So, you know, not every public health unit is the same. And you know, that was a really cool team that came up and showed you this data. At the Perth District Health Unit, we have an epidemiologist and a 0.5 HIA. That's our data team. So, you know, our capacity is limited. We can certainly work with community partners, and that's something that we do every day. We're supposed to use a comprehensive health promotion approach to increase the capacity of priority populations to prevent falls and increase public awareness regarding falls prevention. So that's a mouthful. You could, you know, spend a day talking about what does that mean. So here's an integrated model of population health and health promotion from Public Health Agency of Canada. So seriously, very complex issue right there. And in terms of our capabilities, well, I think collaboration. We work in partnership all the time. We're trying to assert, should I admit it, horizontal leadership all the time and influence the rest of you and how you should do things as well. Knowledge transfer, application of literature and evidence. We just had a very evidence-based presentation about what to do right at the field level in the nitty-gritty. And targeted analysis, again, with a focus on equity and social determinants of health and priority populations. I mean, so often, you know, one of the best interventions is activity and exercise and strengthening. And so, you know, you can set up your exercise program. The people that are going to come out are the ones that exercise, right? How do you get the ones that really need the exercise? So some of our capabilities that align with the BEACH model, that is, again, in the toolkit. Most of you, I think, will be familiar with the BEACH model, which is education, provision of equipment, environment, activity, clothing, and footwear health management. Again, the education component, particularly to the community, social marketing, media advocacy, you know, getting information out to healthcare providers. Equipment, things not the one-on-one, fitting people with equipment, but applying for grants, advocacy for standards and subsidies. This is someplace where public health can sit. Modifying the environment more on a community level again, in terms of municipal planning. We sit on those types of tables where we can influence that. And activity, usually working with community partners to increase access. And again, the target audience for education that we need to reach here is really varied, and I think public health could have a good role there. So what are the challenges? Well, I'm sure you could all think of your own challenges. Bernie I've seen him talk before, and I really envy them with the One Health Unit, One Lynn. This is kind of what we're looking at here. So the question for me is, what do we mean by a regional program? What needs to be regional? What needs to be local? How do we communicate? How do we achieve consistency where we need to achieve consistency? And again, I'm trying to remember why I put this slide in, but in the initial report on public health, this was some of the data. This isn't exactly the same indicator notice. This is fall-related hospitalizations among seniors. So this is one step further downstream. So these presumably would be worse falls because they required hospitalization. And you can kind of see the range in Ontario goes, and this is rate per 100,000 people 65 and up. The rate varies from 942.6 to 2,371.5, which is pretty wide, right? But they're already in the report trying to kind of chip away as well, why might the rates be different? And so some of the health units are rural, some are urban centers, you know, and what are all these factors that make us different? And so all these different regions, we have different challenges, different needs. How do we work together to serve everyone's individual needs? So I think along with challenges, usually there are opportunities as well. And I would just mention that not only in falls prevention, but there are many other areas where I think we can work together and really leverage our complementary strengths and skill sets. And that's it.